In today's class, we are going to deal with the cecum part, that is the proximal part of large gut. So we have got many organs in our abdominal region. So in that we have got intestinal part, which again have two parts, one is small and another one is large intestine. So this large intestines again have got five parts, such as we have got cecum, ascending colon, and then we will be having transverse colon, and then we will be getting the descending colon along with sigmoid colon, and later it is going to end up in rectum. So now we are going to deal with the cecum part alone, that is proximal most part of the large gut we are going to discuss in today's class. So to talk about cecum, it is the enlarged part of large intestine, and it is having same features of large gut, that is large gut is having three important features. One is we will be having appendices epibloicae, that is the fat pouches which are present over here. So these are the fat pouches we have got in the large gut, which is a special feature for large intestine. And along with that we have got a longitudinal muscle running all over, that we will call as tinea coli. And then we have got this saculations because of the attachment of this longitudinal muscle, and this is otherwise known as horstrations. So these are the three important features we have in large gut. So among that, in cecum, we will not be having appendices epibloicae. All other features will be seen, such as tinea coli and horstrations. So in cecum, if we are seeing, we have got four types which I had explained in a diagrammatic representation, such as conical type, and then we have got infantile, normal and exaggerated type. So now we are going to deal with the structures which we can make out here. So this cecum, we have got length 6 cm and breadth 7.5 cm. If you are seeing the cecum anteriorly, it is related to anterior abdominal wall, which we had removed in one side, and then after it is getting related with greater omentum, which you can make out here. So this is the greater omentum, which is also related in the anterior aspect of cecum. So the first relation which is seen in the anterior aspect of cecum is anterior abdominal wall, and then we have removed that so that we can approach greater omentum. And once we remove the greater omentum, we can make out, so once we approach the greater omentum and remove it, we can see some coils of small intestine, that is ileum part related anterior to it. So if the cecum is empty, these coils of ileum is also will get related to the anterior aspect of cecum. So these are the three relations seen in the anterior aspect. Now we will approach the posterior aspect. So talking about the posterior aspect, we have got in posterior part, the major muscle which is getting related is iliacus. So the muscle which we are seeing here is iliacus muscle, which is the first relation of posterior aspect of cecum. And if we remove the cecum, we can approach other structures which are giving posterior relation. So we are removing the cecum with the ascending colon and their appendices epibloicae. So here we can approach the structures, such as we have got iliacus and right psoas major related to posterior aspect of cecum. So this is right psoas major, this is iliacus. Along with that we have got some nerve related, such as the nerve which we are seeing here is lateral femoral cutaneous nerve. So lateral femoral cutaneous nerve and femoral nerve along with genitofemoral nerve. So these are the three nerves getting related with the cecum part. So genitofemoral and then femoral nerve and lateral femoral cutaneous nerve. So these three nerves along two muscles such as iliacus and psoas major are also getting related to the posterior aspect of cecum. So these are the relation of cecum to the posterior aspect.
So in today's topic we are going to see another part of GIT, that is large intestine. So the commencement of large intestine we are going to see in this video. So the organ which we are going to refer today is cecum. So this is the organ which we are going to deal today. So about cecum we are going to see, as I said, it is the commencement of large gut. You know, we have got large gut which is starting from the cecum, that is commencement, which is going to have the ending of the large and small intestine, that is ileum. So small intestine again have got three parts: duodenum, jejunum and ileum. So the terminal part of small intestine will end up in cecum. So the cecum is considered as the commencement of large gut, so which is starting from cecum, and then we will be having ascending colon, which is a continuation of cecum, then transverse colon will be passing, which is going to end up in descending, and then we will be having sigmoid colon with rectum and anal canal. So in such a way we will be having this large gut tube placed. So this is how large gut will be seen. In this we are going to see details of this part, that is cecum. This is ascending colon, transverse colon, descending colon, sigmoid colon and rectum with anal canal. So this is how we have got large intestine forming a loop in our abdomen region. Now we are going to see about the cecum, and it is a asymmetrical sac, that is it is not having a proper half of the bulge. It will be having a asymmetrical shape. About this shape we will see later again. So this asymmetrical sac is devoid of a part of large intestine, that is appendices epibloicae. So if you are taking this large intestine altogether, so this large intestine have got three important features. One is saculations, that is the curves present between the organs. So these things are ostrations or saculations, and along with that we will be having a longitudinal muscle attached. A form of longitudinal muscle will be seen, which will be seen in the specimen. So that is tinea coli. And another feature is we will be having some fat pouches outgrowing from this large intestine. That pouches is called as appendices epibloicae. So appendices epibloicae will be seen. In cecum, while we are talking about the cecum part, along with cecum we will be having a small part called appendix also. About appendix we will deal later. Now talking about cecum, this cecum is devoid of this appendices epibloicae, which is not seen in cecum. So only these two features will be seen in cecum part of large intestine. Now we are going to see anatomical features. What are the other anatomical concepts we have for the cecum? If we are taking the size of this cecum, so if we are talking about the size of the cecum, it is about having a length of 6 cm. So you know, appendix, and then we'll be having the ileum, and then we'll be having cecum ascending colon. So this is cecum. So if you are taking the size of the cecum, the length will be 6 cm, but the breadth if you are taking, it is more, that is around 7.5 cm. So this is the variation seen in only in some of the organs, that is length is lesser than the breadth. So length is 6 cm and the breadth is 7.5 cm. This is an important feature we have to remember. And then we will go on to the shape, that is anatomical shape, how it is differing for this cecum. So we are going to see about shape variation, shape of cecum. What are the different shapes of cecum we have got? So about this we are going to see. As I already said, it is a asymmetrical cul-de-sac, but the shape of the cecum, it varies from varies among the group of population into many types. Especially we have got important 4 types of variation in the shape of cecum. So we are going to consider 4 types of variation. 4 types of variation of cecum. So among that, first type what we are going to see is fetal type. So first one is fetal type. Talking about fetal type, according to the presence of appendix only we are going to see all these things. So we have got our cecum, and this cecum, it is going to form a conical shape in the lower part because of the presence of appendix in the apex region. So this is cecum will be seen as a conical shape in the base part or lower part, where we will be having the apex giving attachment to the appendix. So this is a conical shape of cecum with appendix attached to the apex of this conical part. So this is considered as apex and this is considered as appendix and this is considered as conical shape. So conical shape. Conical shape of cecum, at last it is going to form a apical region in the lower part. From the apex we have got appendix arising, and this type of cecum formation we will call as fetal type. Mostly in children it will be in this type, so we are calling that as fetal type, and it is seen proceeding in adult also only in 2% of population. Now we will move on to another type, that is infantile type. So another type which we are going to see is infantile type. So in infantile type what will happen is this pouch, it is going to invaginate in the lower part. So in the lower part of cecum the bulge will invaginate. So like this it will invaginate and form a quadrangular shaped quadrangular shape or quadrate shaped cecum. So because of the invagination in the middle part of the apical region, we will be having a quadrate shape. So quadrate shape of cecum will be seen. From this depression, we will be having the appendix arising. So appendix will be seen arising from the depression. And this type is called as infantile type. So this type of cases will be seen in 3% of population. So this is how we have got the another type, that is infantile type, which is seen in 3% of population. Here we have got quadrate shaped cecum where we have got an invagination in the lower part or depression from where appendix will be arising, and this type will be seen as or called as infantile type. Now we will move on to our normal type. So another one is normal type. And talking about this normal type, here we have got cecum which is forming a right saccule bigger than the left one. So right saccule will be bigger compared to the left saccule. From there we have got our ileum arising, and here we have got our appendix. So I think you can make out. So here right and left saccule usually will be seen in cecum. In this normal type, right saccule will be enlarged than the left saccule. So left will be somewhat looking reduced in size and right saccule will be enlarged. So enlarged right saccule is called as normal type. From where we will be having, from the junction of right and left saccule, we have got our appendix, and above we have got our ileum. So this type is called as normal type, and it is the most common type, and it is happening in 90% of population. In 90% cases, this is the normal type of the cecum seen, and the length between the ileum and appendix in this type is around 2 cm. Between the ileum and appendix we will be having a length of 2 cm. And now we are moving on to the fourth type. So as I said, we have got 4 types. We have seen 3 types. The other one is exaggerated type. So exaggerated type. So in this type, name itself it indicates we have got a cecum. So in this, right saccule enlarges more, where left saccule, here it is seen at least, here it will get atrophied. So we will be having appendix arising. Along with the upper part we will be having ileum also. So like this we will be having our tube arising. Just above the appendix we will be having opening for ileum also without any distance. So here left saccule is atrophied, only right saccule will be seen. So enlarged right saccule, left saccule is atrophied, and appendix is present near to the ileum. So this is ileum and this is appendix, as you know, which will be nearer, and this type is called as exaggerated type, and this type of condition will be seen in 4 to 5% of cases. So in 4 to 5% of cases we have got this type of shape will be seen. So these are the 4 types of cecum shape we have got. Now we will move on to the position of this cecum. Talking about the position, we have got again 9 regions as you already know. So we are talking about position. Position of cecum. Position of cecum, we have got 9 regions. Among that, here we have got umbilical region, and on the right and left side in the lower part we have got right iliac region and left iliac region. So in this right iliac region we have got our cecum placed. So here we have got our cecum, and this is going to continue in the upper part as ascending colon, as you know. So this is the position of cecum which is seen in the right iliac fossa, and due to some faulty of rotation, sometimes this position will get occurring in the some other place, that is especially it will occur in right hypochondriac region, umbilical region and left iliac region. These are the abnormal positions where the cecum may occur. So this is the normal position. In abnormal condition, because of the faulty of rotation, it may occur in the right hypochondriac region, or in the umbilical region, or in the left iliac region. So these are the cases where it may occur because of the faulty in rotation. Now we will move on to the other details, such as we have got some topography for finding out this cecum. That is nothing but we have got cecum, actually it is covered by peritoneum, and if you are talking about the positioning, for that we have got our topography. So here we have got 2 lines, vertical lines, and this line is called as transtubercular line, which is passing through the tubercle of ileum. So we are calling that as transtubercular plane. So we have got this cecum which is having superior border formed by transtubercular plane, and the inferior border is formed by a fold of groin. And then we have got median margin formed by right lateral plane. We have got right lateral plane which is forming the medial boundary for the cecum. So superiorly it is by transtubercular, and inferiorly by fold of groin, and medially it is by right lateral plane. And it is this fold of groin and the transtubercular plane will be joining in the lateral aspect. So it will be somewhat triangular in shape. The position of cecum will be triangular in shape, and it is covered on all places by cecum. So this is the major feature for the positioning of cecum we have to know. Now we will move on to the general relations of this cecum. So we are going to talk about the relation of cecum. We are going to see about relations. To know about the relation, we have got again anterior posterior relation and all. So first we will see about front relation. So about the anterior relation we are going to see. Anterior, so about relation we are seeing. So in relation we are going to deal about anterior relation first. So talking about anterior relation, we have got cecum. Anteriorly it is related to anterior abdominal wall, and then we have got our greater omentum placed. We have got our greater omentum placed in the anterior aspect. So this is anterior abdominal wall. So in anterior abdominal wall, which I am not showing over here, just it is related to anterior abdominal wall. Between that and cecum we have got greater omentum placed. I'm sorry about this. Greater omentum placed. And then we will be having some coils of small intestine also will be related over here, while the cecum is empty. When the cecum is empty, we will be having some coils getting related over here, and those coils are nothing but coils of small intestine. Coils of small intestine. So these are the relation we have got in anterior aspect. First is anterior abdominal wall, and the second one is greater omentum, and the third one is coils of small intestine. Now we will move on to our posterior relation. So talking about the posterior aspect. Posterior relation, we have got our cecum. So if you are seeing the posterior aspect, we have got right psoas major muscle. First we have got a muscle over here, and that muscle is called as right psoas major muscle. Right psoas major muscle. And along with this muscle, we have got a nerve transmitter. So that nerve is called as genitofemoral nerve. And a nerve is passing that we are calling as genitofemoral nerve. Now, then we have got again another nerve, that is lateral femoral cutaneous nerve, and also a trunk of femoral nerve. So we are having again two more nerve. One is lateral femoral cutaneous nerve, and then one is trunk of femoral nerve. So trunk of femoral nerve will also be seen over here. So we have got psoas major, genitofemoral nerve, right genitofemoral nerve, and trunk of femoral nerve, trunk of femoral nerve itself, and this is lateral femoral cutaneous nerve. Lateral femoral cutaneous nerve. So these are the structures seen in the anterior and posterior aspect of the cecum. Now we will move on to above and medial relation. So above and below relation we have already seen in this image, that is. So we have got in this image above relation, that is it is by transtubercular plane, and below relation. So this is above relation and this is below relation. Below it is by fold of groin. So now we will move on to the medial aspect relation. Talking about the medial relation. So talking about medial relation, we have got a cecum. Cecum with appendix and ileum. So this is how we have got cecum. So in medial relation we have got two important structures present, that is one is appendix in the lower part. So medially we have got appendix related, and then we have got terminal part of small intestine, that is ileum, and between the ileum and the appendix in the lower part or inferior part of the ileum we have got a recess of peritoneum that we will call as inferior cecal recess. So these are the relations seen in the medial aspect. We are talking about anterior, posterior and medial relation. In medial relation these are the two important structure we have got, and sometimes we will be getting a peritoneal space over there, that is called as inferior cecal recess also related. Now we will move on to the arterial supply of this cecum part, and before going to the arterial supply I prefer we have to know about interior of cecum better, then we will move on to those arterial aspects. So first we will move on to interior of cecum. So we are going to talk about interior. So interior of cecum, if you are taking, we have got cecum. So like this we have got cecum. In this we have got our appendix over here, and here we have got our ileum. So now in the interior we will be having some folds, that mucous folds will be seen. Along with this we have got two orifices placed. One is appendicular orifice, another one is the ileal orifice, ileocecal orifice to be frank. So this is we will call as ileocecal orifice. So and this is appendicular orifice. So these are the two orifices we have got in the interior of cecum. So this is ileocecal orifice and this is appendicular orifice. This is the appendix. This is ileum. Now we are going to see details of these two orifices, and these two orifices are actually guarded by a valve. So we have talking first about ileocecal orifice. So to talk about ileocecal orifice, it is seen in the posteromedial wall of the cecum. So we are taking interior of cecum in the posteromedial wall. Posteromedial wall, we have got this orifice present, and this orifice is guarded by two lips. It is guarded by two lips, and those lips are above we have got a lip called upper lip and lower lip. In this upper lip, if you are seeing, it is horizontal. So upper lip, it will be horizontal in shape, and if you are seeing lower lip, it is concave in shape. So upper lip, it is horizontal, lower lip, it is concave in shape. So it is guarded by two lips above and below. The upper one is horizontal, lower one is concave. Both the things will together join on the sides. It is going to form an extension. That extension is called as frenula. So both the lips, it is joining together on each side to form an extension called frenula, which is seen on either end of the orifice. So above the orifice, these are things we have to remember: ileocecal orifice, how it is guarded, what are the lips placed, and what is the extension present in the sides of the lips. Now we will move on to appendicular orifice. So appendicular orifice, nothing but it is a circular orifice or circular opening. Circular orifice which is present 2 cm below the ileocecal orifice, and it is again guarded by a submucous fold. This is again guarded by a submucosal fold, and that fold is called as valve of Gerlach. So a fold is seen covering this orifice, and that is called as valve of Gerlach. So these are the important features seen in the interior of cecum. So now we will move on to the details of the basic concepts, such as we have got some arterial nerve supply and lymphatic drainage as like for other organs. So we are going to see about those things. Talking about arterial supply. Arterial supply, it is mainly by two branches which is coming from ileocolic artery. So we have got our cecum, appendix, ileum. So now we have got our superior mesenteric artery. That superior mesenteric artery, we have got our superior mesenteric artery, and from superior mesenteric artery we have got an artery called ileocolic artery. From the ileocolic artery we have got anterior branch and posterior branch coming. This posterior branch, it is coming over to cecum, and it is supplying this posterior surface of cecum. Along with that, it is going to supply the appendix also. So this is superior mesenteric artery, which is going to give a branch called ileocolic artery, which is again divided into anterior and posterior branch. The posterior branch, it will supply the posterior surface of cecum. Along with that, it is going to supply the appendix also. So this is cecum. Anterior surface is supplied by anterior branch, posterior surface supplied by posterior branch. The posterior branch, after supplying the posterior surface, it is going to supply the appendix also. So this is about the arterial supplies. Talking about venous drainage, same thing. It is the corresponding vein is going to have the venous drainage. So we have got our ileocolic vein, which is going to drain in superior mesenteric vein. Superior mesenteric vein, which is going to drain the ileocolic vein. So we have got our ileocolic vein, which is draining into superior mesenteric vein as venous drainage of cecum. So now talking about lymphatic drainage. We have got our lymphatic drainage. So this is venous drainage. Talking about lymphatic drainage, it is very simple. Same like the other things. We have got appendix, ileum. Now we have got between the ileum and appendix. Ileum and appendix, we have got some group of lymph nodes present, and those lymph nodes are known as ileocolic lymph nodes. So we have got drainage for cecum. The cecum is getting drained into ileocolic lymph nodes. Ileocolic lymph nodes. From the ileocolic lymph nodes, it is going to pass and reach the, we have got again aorta. From aorta we have got superior mesenteric artery. So this is aorta, superior mesenteric artery. And now from near to the superior mesenteric artery we have got our some group of lymph nodes, that is superior mesenteric lymph nodes. So there it is going to drain. From the ileocolic lymph nodes it is going to drain in superior mesenteric lymph nodes. So this is the lymphatic drainage, ileocolic to superior mesenteric. Nerve supply, it is by sympathetic and parasympathetic as like others, and it is mainly by sympathetic T10 to L1 segment. Parasympathetic, it is by both the vagus nerve. So these are the features, main important features of cecum we have got. So cecum during situs inversus, it may happen to relate to other fossas or other regions of our abdomen, such as left iliac fossa, or else in umbilical region, or else in hypochondriac region, because of the situs inversus condition. So these are the features or anatomical description of cecum we have to get.
So now we are going to approach the cecum again in a slide view, such as we have got a picture over here which is showing the large intestine on the whole. So this is the proximal part of the large intestine, that is cecum, and then with cecum we have got two more structures which is getting inside the interior of cecum, that is we have got part of small intestine, that is ileum, and in the lower part we have got appendix, and this appendix position it may vary from individual to individual, that is it is having so many positions, such as 6 positions are there. According to the way it is directed, we have got 6 positions. We will discuss that later. Now cecum, it is going to continue in the upper aspect as ascending colon, and then after we have got a colic flexure, we will call that as right colic flexure, which is present below the liver. So we are calling it as hepatic flexure, and then after this ascending colon is going to continue as transverse colon. Later it is going to form another flexure called left colic flexure, which is present below the spleen. So we can call it otherwise as splenic flexure, and it again descends downwards as descending colon. Later it is going to continue as sigmoid colon in this part, and the sigmoid colon going to continue as rectum and then to anal canal. And we have got some 3 important features as we discussed earlier for large intestine, such as the longitudinal muscle which we are seeing in the middle part of this tube. This muscle we will call as taenia coli, that is the arrangement of longitudinal muscle present in large intestine we will call as taenia coli, and with that we have got this horstrations or circulations present all over the large intestine except the rectum and anal canal, and then we have got some fat pouches which are popping out from the large intestine. We will call that as appendices epibloicae. So these are the features which we can make out in large intestine. So in cecum, if you are seeing, you will be having horstrations and taenia coli, and appendices epibloicae is absent. So now we will detail with cecum. So large head features, as we discussed, saculations, appendices epiploicae and tinea coli. You can remember a mnemonic SAT. So as we discussed, ostrations and appendices epiploicae with tinea coli. So same. So tinea coli again have got three parts such as tinea libera, omentalis and mesocolica. So about that we will have a separate class. Now we will see details of cecum. So before going into the detail of cecum, just posterior abdominal wall structures we will approach so that it is easy for us to relate the cecum with the posterior aspect. So in the posterior aspect, right side we have got cecum related to right iliac fossa. So in that region we have got muscles which are two in number. One is iliacus or right iliacus muscle and then one is right psoas major muscle. Here you can make out some nerves which are coming related to cecum. That is, three nerves will be related to it. One is lateral femoral cutaneous nerve, femoral nerve and genitofemoral nerve, which are the structures related along with these two muscles to the posterior aspect of cecum. So psoas iliacus and right psoas major, those are quadratus lumborum, which is not having relation with cecum, just for posterior abdominal wall muscles. Look after, this is quadratus lumborum. And the nerve, lateral femoral cutaneous nerve, and then we have got femoral trunk along with genitofemoral nerve. So now talking about cecum, as we discussed, it is present in the right iliac fossa. If proper rotation of gut is happening, cecum will present in the right iliac fossa. And the size of it have a special significance that length is smaller than the breadth of this particular organ. So cecum length is 6 cm, breadth is 7.5 cm and is always considered as a blind sac with peritoneal relation, which is covered all over by peritoneum except a small part in the upper area of posterior surface. And talking about the shape, we have got various shape, especially four types are there: fetal type, infantile type, normal type and exaggerated type, which if you refer the diagrammatic representation I had shown before, you can understand that. And we have got some topography for relating this cecum. That is, we have got two lateral lines and we have got two lateral lines on either side which is passing through mid-clavicular line and two transverse line which is a transpyloric and transtubercular plane. So now we are taking the area between the transtubercular and right lateral plane, and here lateral to it you have got this blind sac pouch present that we will call as cecum, which is bounded below by fold of groin. So this is a triangular area where we have got cecum, which is bounded above by transtubercular, medially by right lateral and below by fold of groin. So if we are going to relate with some structures now, such as general relation, anteriorly we have got anterior abdominal wall first, then after we have got greater omentum present covering this, and then we will be having in empty cecum related to coils of small intestine, that is ileum. And then we have got, that's it. So we have got coils of small intestine in anterior part. So now we have got posterior relation, which is otherwise known as cecal bed. We have got relation of right iliac psoas, that is iliacus and psoas major muscle, which is covered by fascia iliaca. And then we have got some nerves related. As we discussed, we have got three nerves. One is genitofemoral nerve, and then we have got femoral nerve, that is trunk of femoral nerve, along with lateral femoral cutaneous nerve. We can make out a recess just below the cecum. We will call that as retrocecal recess, which you can approach in this picture. So then we are going to see the above relation, that is nothing but it is going to continue as ascending colon. And we have got below part which is related to inguinal canal, which we are calling with skin as fold of groin. And then medially we have got relation of two tubes, that is we have got ileum along with appendicular tube which is getting opened into cecum, and we have got infracecal recess present over here. We will call that as bloodless fold of Treves. So inferior ileocecal recess we will call as bloodless fold of trace which is present here in this area. So these are the medial relation, ileal opening, appendicular opening with bloodless fold. And talking about the interior of cecum, we have got two openings. One is ileocecal orifice, another one is appendicular orifice. So here you can make out the above one we will call as ileocecal orifice. This is appendicular orifice here. So ileocecal valve and appendicular opening. So these two are present in the interior of cecum. So in this, the appendicular valve is guarded by a appendicular orifice is guarded by a valve called valve of Gerlach, and the valve present in the ileocecal opening. Here, lateral aspect we will call that as frenulum. And talking about blood supply, the blood supply for cecum is coming from ileocholic artery by its two branches, anterior and posterior cecal branches, and then anterior branch it is reaching the cecum via superior ileocecal fold. If you are talking about venous drainage, same way we have got ileocholic vein which is getting drained in superior mesenteric vein. So this is anterior and posterior cecal arteries. So lymphatic drainage, it is mainly by ileocholic lymph nodes which are present near to the junction of ileum and cecum, and then it is going to drain in superior mesenteric vein. Nerve supply, we have got sympathetic and parasympathetic. Sympathetic, it is mainly by superior mesenteric plexus and also from T10 to L1 segments of spinal cord which is giving sympathetic supply. Parasympathetic is mainly by vagus nerve. And for identification purpose, this diagram you can make out. Here we have got lateral femoral cutaneous nerve, this is genitofemoral nerve, and lateral to it we will be getting femoral nerve, and psoas major muscle, this is iliacus muscle. So the valve you can make out ileocecal opening with frenulum, and this is appendicular opening with valve of Gerlach. Same picture. So this is twisting of cecum. Some case it will happen. So this is the picture showing the twisting of cecum. So sigmoid volvulus, it will be happening in this region. Actual position is here. If it is getting twist, it will reach in this part. And cecal volvulus, if it is getting twist, it can occupy epigastric region, or else it can occupy left iliac region and left lumbar region. So thank you for listening. So all these are the details of cecum. We will just get to see the appendix details also in the same class. So along with cecum, we have got another organ attached to it. We will call that as appendix, which is having a length which is varying from 2 cm to 20 cm, average being 9 cm, and it have got some parts such as base, body and tip. So here you can make out this is the basal part, body, and the tip part, along with mesoappendix, that is peritoneal fold attached to it. So here base, and then we have got body, then we have got tip, and this is mesoappendix. So it is attached to the posterior-medial wall of cecum, which is about 2 cm below the ileocecal junction, and here we can make out this properly by understanding the base where all tenues of cecum will converge together. So it is going to act as a guide for the identification of appendix. So to identify appendix, we can approach from cecum where all tenues meet. There we will be getting the base of appendix arising. So here you can make out this is the appendicular part, mesoappendix, this is ileum. So this is another picture showing the opening of appendix over here. It is in posteromedial wall of cecum. Talking about body, we have got narrow tubular, and it is containing a canal which is going to get open in cecum. The cecal opening is guarded by a valve, as we discussed. It is valve of Gerlach. Talking about the tip, it is least vascular, and the arterial supply given over appendix are all end arteries. It is directed in various positions. Because of its direction, we have got various positions of appendix, and the name of the appendix also will differ, such as according to position. We have got around 6 positions for this. We have got first a 2 o'clock position, that is directed towards the spleen, which will be present over here. And in that we have got 2 types again. One is passing in front of ileum, another one is passing behind. So we can call that as pre-ileal and post-ileal type. So this is post-ileal type. So this is 2 o'clock position, otherwise known as splenic position. Another one we will call as 3 o'clock position, which we will call as promontoric position. And this promontoric position, it is directed to the sacral promontory. And when we have got pelvic position, which is otherwise intimated as 4 o'clock position, which is going towards the lesser pelvis of the hip bone. And then we have got subcecal position, which is around 6 o'clock actually. This is 6 o'clock position, and which is going towards the inguinal region. And then we have got 11 o'clock position, that is retrocecal position. This is the retrocecal position, which is going in the upperwards behind the this is marked, this is inguinal position. Okay, this is inguinal position, and the thing which we are seeing here, 11 o'clock position, is called as subcecal, and this is the retrocecal position, which is 12 o'clock position. So we have got splenic position, then we have got promontoric, pelvic, and this is actually inguinal position, and here we have got subcecal and here retrocecal position. So this is retrocecal position. So this is the lesser pelvis towards the pelvis. If it is directed pelvic position, this is the promontory of the sacrum. Here you can make out promontory of sacrum, where we have got positioning towards the 3 o'clock. So here pelvic position. And mesoappendix, it is a peritoneal fold which is triangular in shape. It is going to invest the entire appendix, and it is derived from mesentery of ileum, which you can make out here, triangular shape. Arterial supply, we have got appendicular artery, which is a branch of inferior division of ileocholic artery, and a recurrent branch anastomosis with the posterior cecal artery towards the base. All the branches are end arteries, and tip is least vascular. So in obstruction of artery, gangrenous change will happen immediately in the tip of appendix. So this is how arterial supply is given. It is mainly from inferior division of ileocholic artery. So venous drainage, all the corresponding veins are getting drained into superior mesenteric vein. Lymph nodes, superior mesenteric lymph nodes, it is at last going to drain, but it is passing through ileocholic lymph nodes, which is present at the junction of ileum and cecum. Nerve supply, same like we have got umbilical region. Sympathetic supply will be by T10 segment. So same, now it is going to supply sympathetic for appendix. So if any changes is happening in appendix or any infection is happening in appendix, it is felt in the umbilical region because of its nerve supply, that is T10 segment. Parasympathetic, it is mainly by vagus nerve. So that's why pain is referred to umbilical region, because of same nerve supplying the umbilical and appendix region. So applied aspect, inflammation of appendix is known as appendicitis, and it is manifested by pain, vomiting and temperature. And pain is often felt first in the umbilical region, then it will move on to right iliac fossa, which we will call as local peritonitis, and it is associated with tenderness and rigidity that we will feel in McBurney's point. So we have got many tests for us, such as Soya's test. If it is retrocecal appendix, the pain is felt in the right hip joint while they are extending due to irritation of right psoas major muscle. So this is Soya's test. So these are the details of appendix we have got. So cecum and appendix both are considered as important, especially the types of cecum and the positioning of appendix are very important, along with interior of cecum. And if you want to refer, you can refer the diagrammatic representation of cecum and appendix for better understanding.